Our next speaker is Dr. Sathyan, sir. He is the director of Sathyan Eye Care and president of Glaucoma Society of India. Sir is the most humble person, and he's a great teacher also. So he'll be talking on structure and function correlation of glaucoma assessment and progression.
Thank you, Nimita. Wonderful to be here. It's always been a pleasure to be here in Kerala conference, and not only in the conference, being in Kerala itself is a great feeling. I've seen Nimita as a child. She graduated in the medical school, now as an ophthalmologist and becoming a glaucoma specialist under Bindu's leadership is amazing. I'm really happy to see you here, and inviting me to be a speaker in your session is a pleasure to be here. So wonderful talks, all of you have given great talks. I wish that you really go into the depth of each talk, what is really practical for people to really practice, so that we use it in our daily clinical practice, than just giving a theoretical aspects. So we'll just discuss that in case there is some time to be discussed. So looking at the structure function correlation, so how do you really relate these two together? This is like husband and wife. That is a very superficial relationship, I can say. But if you really go to the depth of it, it is more like a mother and a baby relationship for the structure and function relationship. The relationship is so deep, any change which happens in the structure, many a times we really may not be able to assess the function, or we don't know how to read the function. That's the problem we have. Because we keep seeing some talks in the conferences, or somebody has taught you something, you just follow it up. But try to apply the knowledge in everyday clinical practice so that you become much better than what the people just teach you or you read through the books. So when there is a damage, it may be a very minimal damage to the entire structure, probably has gone off. So what is the real functional change that you can really see by means of X instrument? And how much you know about that particular instrument? We have quite a good number of instruments today to either early diagnose glaucoma or pre-perimetric or even pre-OCT glaucoma. So that is the ERG, pattern ERG we have. So we can diagnose even pre-OCT glaucoma also. So it is not that number of equipments we are lagging, is that we have something, is that our axons have been reasonably stimulated to look at what is there going on. So structure function we can look at both subjectively as well as objectively by both the structure and function. So looking at the retinal ganglion cell loss, we have a lot of retinal ganglion cells, probably a million cells. I'm not sure whether you have heard my talk on million cells earlier. So we have million cells. Can we really understand these million cells, what's happening to these million cells? It is not only the glaucoma which damages the RGC. Of course, there are other reasons. There is a trauma, there is a neurodegenerative diseases, there is a vascular diseases. There is enough number of toxic optic neuropathies which we have not looked into. We know that what is Kerala famous for, what is Tamil Nadu also is famous for. But we never looked at in the OCT or the visual fields, are we really picking up these, and then we are reasonably explaining them, don't do this anymore. Or probably you just continue so that you keep coming to us. So the importance of structure function loss is where we can really understand, either first is to diagnose and to understand the severity of the disease. In glaucoma, we say mild, moderate, severe, and advanced. So we need to grade the disease so that the disease can be managed better. We need to understand what is the progression happening in the disease. It is just not enough. You see one, what you call the sheet of paper, which most of the people come with their own big files, which I never feel comfortable with. Then you just compare one with another one. It is not that. Today, the algorithms are completely different. You cannot just compare with one picture to the other picture. We need to use our systems. Each company gives their own algorithms to understand how the progression is happening in each location. The math is much more deeper than what you just compared in your papers. So the progression of the disease, understanding that is extremely important. If you don't understand that, then entire thing is just wasted. The third part is understanding the nature of the disease. Is that disease what you are really looking for, or your mind is fixed to only one thing? IOP 23, patients should be having only glaucoma. That's how we are mentally tuned to. So just get away from that first and try to understand there are many diseases can be just associated with, or there may be just no glaucoma, but maybe something else is there. So you can see here, it is very typically, you can see that there is a damage and which is picked up by the visual fields. And also, I'm a big fan of the octopus visual field, though I was a user for almost 20 years. I was using Humphreys, but I switched over to octopus. But octopus gives you amazing results. I'm not here to promote, but if you want to really realize that, then you have to buy and use it for some time. So it gives you the structural relationship also. You can see that for me it is the left bottom, and then I'm just showing you with one red arrow there. That is the damage, how it is picking up with the octopus. That is a physical damage. So this is the progression chart. If you really read only from your printouts, again there is no use. I'm really focusing on don't use the printouts. Use the machine. Try to access the machine in your own systems. And see, this is a very fantastic printout. I mean, from the machine, you can see the right eye as well as the left eye, how each location there is a progression happening. So how much is the total deviation? If you, okay, you have the other mic. Okay, let me just, you have a red one. You can see those triangles. The triangles indicate it is a different machine. It is a different octopus machine. That is 300 series, and you can see the squares. That is a 900 series. So we know each machine, which machine is being used, how it is being plotted. You can see that you have one. Yeah. Thanks. Which one? This one. There's no arrow. Arrow you cannot use. You have to just activate that. So I'm not sure whether you can see that. Anyway, I'm just sorry that. So you just see that each location, how much is the diffuse loss, and you see the LD. LD is the localized defects. That is a glaucoma specific, you can say. And you can see every time when the patient is doing the test, the initial phase you can see the triangles, the LD in the right eye, OD you see, or OS you see that the triangles have removed it. You can select whichever you want to see the progression. I'll show you in another chart. Is it activated now? Okay. Can you just give me this, at least this tracker? So just to understand that, you can see the progression in a very detailed way. I would have been happy if the previous speaker was using it, and if it was not working, done something with it. Anyway, that's okay. We'll just manage it. So this is the serial analysis again from the octopus visual fields. So try to understand each field, which type of field you have done. Okay, this is a handicapped. So in the top one is the, you can see in the top, which one, is it a dynamic one which we have done, is it a top we have done. So here you see this, what type of a visual field test is been done. It is something like a 24-2 or 30-2, something like that in the Humphreys. Here also it is given as G dynamic or G top. You see here over a period of time, each year, and how the things are happening. Everything is so important for you to understand. And also, it is not enough for you to just see the progression in the OCT, but you see which location, whatever is here, you go and click this and see each location. It is usually the OCT gives you, usually the OCT gives you only the total loss. It doesn't give you each location. If you don't see each location, whichever is important for you, like superior or inferior, then again you are lost. You are not seeing the true progression of the disease. Just check whether this is the batteries. Just at least manage it for the next presentation. So I'll just give you some examples. I'll just quickly go through that. So you can see in this patient there is a typical inferior RNFL loss, and this is a 45 years old gentleman. Period is between 21 to 23, and you see that structural damage in the fundus photo. You have to have fundus photograph as a compulsory thing, but you have to have a good fundus photograph machine so that you can really understand where exactly is the damage happening, and then have the OCT done. Try to see whether both are correlating or not. If it is not correlating, understand what is really happening. And also you see that the visual fields also correlates with the same thing. This could probably be the NTG pattern. Is it really the visual fields? This could be a AON pattern also. So we have to understand whether there is a true RNFL loss in the inferior zone in the fundus, which is really projected as the OCT and also in the visual fields. And also you see that whether there is a progression happening over a period. Not every patient is comfortable in doing the visual fields, but is that the OCT is reasonably good enough to understand the progression of the visual fields over a period of time? Definitely yes. You do the OCT, that gives you a reasonable amount of understanding how and each area or each location in the visual fields can possibly progress. That is a prediction. That is the one thing which I was just running through fast as the time was running. So you can understand that over a period of time how much is the change happening. Each location again you will have to go through. And this is the case number 2. This is a 50 years old gentleman seen in the year 2013. You can see 21 and 22 is the IOP, and this is the fundus changes. And see that there is a very stable visual fields, not changed much. Again, this is the same thing. But 2013, and you see this 2019, can you see the field change? How much it has progressed? Suddenly there is a change in the damage, where the patient was, though he was using whenever he comes for the follow-up. So I used to see the IOP as under control, but whenever he comes for the follow-up, he uses. But we are surprised to see why there is an increase in the damage. So patient can take you for a ride without you understanding anything about him. So you have to understand, so there is a huge change, but there is a red one I have put in. So that is a different field test done, though it looks like as though the fields had improved. But if you see on the top, it is a top strategy which has been used. So the top strategy will not give you much of a details. So we have to understand each and everything, whatever you are doing, so that you are in the right track. This is just to show you how you should really analyze each location and each test, whatever you are doing. So I'll just go through this. So there is a significant progression, but what has happened is once the patient was treated and advised to use it properly, now the visual fields are again stable. So we can look at each location. So again, this is the OCT to show each. What I was focusing is only on the inferior temporal and the superior temporal regions. These are the two locations where you can see the damage possibly occurring. So I'll just go through another case. This is a case number 3. This case I'll quickly go through. So this patient is a 35 years old lady. We have seen it in 2023. It looks like there is a significant damage in the right eye, and left eye seems to be fine. This is the OCT, which really has picked up the inferior RNFL damage, and same in the visual fields. But what is interesting is in the left eye also it has picked up the change. So we have repeated the OCT in a different machine. This is the spectralis. Fortunately or unfortunately, the spectralis has picked up both the right and the left eye. There is a damage. This is the right eye, and the left eye also there was a damage. So you can see in this there is a change which is occurring in the papillomacular bundle area. So this lady has turned out to be both having the glaucoma as well as multiple sclerosis. So slowly it is picking up in the OCT. Now she is full-blown multiple sclerosis with the optic neuritis, everything is happening for her. So this is one of the reasons why I was saying that it is just not enough. So they may be giving you some areas of changes which you may not be really understanding. You may think that is absolutely normal. So this is another one, case number 4. You can see again there is a damage. Sorry, is it going back? Okay, this is another patient. So this patient is had a trauma, but it is not only the trauma which is causing the glaucoma, but the patient had a traumatic optic neuropathy also. So you can see in day 1, 1 month and 3 months how there is a progression happening. Though the cupping is not much changed, but you see how much the OCT has changed. So trivial injuries you really may not notice. Whatever is the major injury in the eye, you will notice. But the trivial injury over the forehead and the temple is not being noticed. But you see that there is abnormal progression of the damage. But whenever you have a damage by the glaucoma, it takes about 12 weeks, 8 to 12 weeks to set in the damage. But you see this within 3 months, how much of a damage has been shown up in this. First month itself is shown up. 3 months later, it has shown up much more. So it is not enough for you to just see the damage. So is that damage because of the glaucoma, or is that damage because of the other reasons which is happening also you must pick up. So you can see that again how much is the RNFL loss progressing. Within the first month itself there is so much of a change. Usually that doesn't happen in a glaucomatous eyes. That happens only after 3 months of onset. So what I'm trying to say is, so this is one chart which gives you a quick example of, I'm exceeding my time I think. Initial phases OCT really helps you, but when the patient is having a more damage, then you'll have to go with your visual fields more so. Even before the OCT, if you want to really pick up the glaucoma, then you have to do the pattern ERG or something called as a photopic negative response, PHNR in ERG, that gives you an idea whether this patient is having a glaucomatous damage or is the cells are under stress. This we can really pick up by doing the pattern ERG. So it is just not enough for you to see the green, yellow or red. It is how your brain uses that red, green and the yellows. so that you can really pick up what is damage, what is the actual disease, and how much is the progression happening. So thank you so much.